I see everyone decide to leave when I came to talk, which is good. I'm gonna relieve Dr. Watkins of introducing me because I have to stall a little bit because we've got to get my presentation up. So my name is Diab, D-I-A-B, and I've been here since I came to UCSF in 2002, having been at the University of Washington. I apologize for this. I had my talk ready, but it's on a computer that someone doesn't have anymore. So I apologize for that. But while I'm doing this, I'm supposed to talk about open hip surgery, which to a primary group I can't imagine would be interesting. So I'm going to ask you questions instead, and I'm going to show you a case. Can somebody tell me define the hip in one word? Begins with J. Come on, try. Joint, thank you. It's where one bone joins another. The questions get more complicated. Seriously? I gotta do it. All right, so what kind of a joint is it? Yeah, ball and socket, exactly right. Exactly right, ball and socket. Why do you have a ball and socket at this location? So you can put your foot in space, all right? As you get further and further away from the core, the joints become more and more restrictive. So your finger is just in one direction, okay? Your elbow's in one direction, but your forearm goes this way, but you need two of them. The hip, you can do it all. So where else do you have that? What's that? Shoulder, exactly right, the shoulder. Same thing, same concept, right? Okay, so can you guys see this, what I'm doing right now?
Not yet.
Oh no, can you show them to them? I want to show them this. Okay. Oh, you can't? Oh, you can't?
Yeah, not until you
all right.
We'll load
That's okay. The good thing about this is, unlike Dr. Wong's talk, which was so good, the clunkiness of this will keep you awake. So, and I've put together this image library of cases, and it's so rich that it's like 1 million clicks to get to any one talk. That's why probably one of the reasons why people don't use it. But I've got a talk here that's really quite good. It's a case with this concept that, and I'm going to download this, is that correct?
Yep.
Okay, great. Do you want to take over from here?
Yeah.
Okay, great. So while he does that, so you've got a shoulder joint that's ball and socket, right? And you've got a hip joint that's a ball and socket. But they're different. Okay, I know that this idea that, orthopedics all the same, just banging away in the OR. It's not. There's a lot of subtlety in orthopedics. Does anyone know any difference between the shoulder and the hip? If I ask you, I'll ask you a different way. The shoulder is a what tissue-dependent joint? What tissue does the shoulder depend on more than anything else? Has anyone ever had shoulder surgery here? No one? That's impressive. It's a muscle-dependent joint, which is why everyone's complaining about their rotator cuff, right? Earlier today, Dr. Swarup was talking about, well, you'll be okay until your 5th and 6th decade. Well, I'm in my 5th and 6th decade, and I'm nervous about my hips. Is it there now? It's ready to go. Good, and is it presentation? Yeah, great. Yep. Okay, good. But let me just finish this, because it's an important detail, just so you guys understand what we talk about in the hip. The shoulder is a muscle-dependent joint. So the most operations you do on the shoulder are rotator cuff. You do other things, but that is the most. What is the knee? Now that you've heard me say the operations you do the most are, what is the knee? What tissue does it depend on the most? What are people getting on their knee? Ligaments, ACL, right? Come on, all the pro athletes, right? So the knee is a sloppy joint, and it needs its ligaments. Ligaments are tissues that attach one bone to another. They're not tendons, they're something different. But the knee needs that because it's very sloppy, okay? The hip is a what tissue-dependent joint? Not labrum. Labrum is important, but not labrum. What tissue does it depend on? Bone. That's why we do all this bone work. we're not doing ligament work on the kids with hip problems. It's all osteotomy, So anyway, and I'm supposed to talk about osteotomy, but I can't imagine talking about that to you guys. So I'm just going to show you a case. So you can see this first slide, correct? And the patient is 4 months old in the first image. Does anyone see anything on there that's abnormal? Why is she in a Pavlik harness? Yeah, and it says here Barlow sign. So Barlow is a man who wrote a paper in the 60s. It's unbelievable to me. I still don't believe that he did it, okay? I suspect him. But it's a classic in our world, Barlow. And he wrote a paper where he examined 9,000 hips. I can't imagine examining 9,000 hips, all right? And from that paper came many things. And it's a really good paper for us. But one of the things came his technique of checking for hip instability. So Barlow, the ball is in, and you bring the legs together, and it slips out. Ortolani before him had said, when you open the legs, you can feel the ball clunk in. Okay? So this girl was Barlow positive. She rested, located, but she could slip out. All right? But if you look at her x-ray, it's not great. And what do we look at? If I look at this bone right here, can you see my cursor? Ah, blast. Okay. If I look at this, it kind of points here. You may think this is subtle, but to us, we notice. If you look at this, it kind of points a little bit to the side. It's not dislocated. It's subluxated. So subluxated is sub, meaning a little bit less than luxated, dislocated. Okay, so it's a little bit out. It's in the socket, but it's kind of sitting on the rim. So we treat that, okay, because we need the ball to be in the socket. The hip is a bone-dependent joint. It has to fit precisely. The knee doesn't have to fit so great. The shoulder doesn't have to fit so great. Okay, but the hip has to fit exactly. Okay, so even a little bit off, we don't like it. Okay. And so she's in a Pavlik harness because in the first 6-ish months of life, you put him in a Pavlik harness. Pavlik is a guy, it's not a pelvic harness. He's a Czech guy who wrote this paper in the 50s. So Pavlik harness. And even here, she's just still a little bit. This specific nucleus is smaller than this one. The acetabulum and the femoral head stimulate each other. When you have an ill hip, the ossification is delayed because the forces are abnormal. So we see that and we go, oh, it's a little bit too small. Teeny bit sitting out, and these are subtle, but we keep her in her hip abduction brace. And then by 2 years of age, we'll make a surgical decision to cut the bone or not. And she looked pretty good to me there. So I left her alone. All right. Are those useful, those x-rays? Do you guys feel like you understand those x-rays? And then I followed her. So why do we, I mean, she's normal at 2, so why do I follow her? I mean, she's normal. So the problem with hip dysplasia as a diagnosis is once we get our claws into a patient with hip, we won't let go. Okay? And I actually think that's an issue because let's say someone comes to see me with a hip ultrasound for breach. You heard earlier in hip dysplasia, a British, I'm an American product, but a British, I'm now referring to 2 people from Britain. Another British surgeon said there are problems of production and problems of packaging. So problems of production are genetic, inherent to family history. That's your big risk factor. Problems of packaging are external. Production, intrinsic, internal, genetics. External, breach. So why is breach a risk factor? I think most people will get that genetics is a risk factor because it's familiar in every disease. But why is breach a risk factor? Yeah, what about the position? Why, so you can still deliver the, okay, so legs are up, you're describing reaching, you're telling me why.
Adduction.
Yeah, so adduction would imply that the ball's going to dislocate. No, they can be in, but I just want you guys to understand, because a lot of what we do is based on this principle that one bone stimulates another. So in the previous exercise I showed you, the occipital nucleus is a little bit small, so that's something that we pay attention to. So when you are, so the socket is like this. In the middle of the socket is a growth center. It's called the triradiate cartilage, because the hemipelvis has got 3 bones, and each one contributes a growth plate. That's why it's triradiate. Okay, how do you stimulate that? By doing it by being like this. That's why you have pavlicardis. That's why you have abduction brace. Everything is up and out. Because here's my socket. As I stand, this is my socket. You guys can't hear me, damn it. No, I'll carry this. I'll just carry this. I'll carry it. So as I stand, this is my socket like this. So how am I going to stimulate my socket? I want to be orthogonal. So I need to bring my leg out like this. If I am breech, I'm like this. That's a completely different force. Okay, so that's why breech has a higher rate of hip dysplasia. Because the child, and so think about it, it's not just I was breech for a day. You have to be breech for a while, okay, because you're in the molding process, all right? And so we get a patient who has been breech for a month, and they get an ultrasound. And what we know is that ultrasound raises the rate of hip dysplasia by 10x, okay, which is problematic. Okay, which is why I do my own ultrasounds. With respect to the radiologist, I just do my own ultrasounds because I don't want to give the patient a diagnosis of hip dysplasia. Because if I do, I have to follow them until maturity. Okay, so I do my own ultrasounds, and we get this because you will see a patient who has an alpha angle of 55 degrees. I don't want to call that hip dysplasia. I just sort of say, hang in there, come back and see me, we'll check again. The problem is now they have a radiology report that says, and I'm not criticizing radiologists, they have to do this, they have to report what they see. Okay, you ask them for a test. In fact, you'd be worried if they didn't, right? But now it's in there, and it's the controversy of whether or not they have hip dysplasia. All right, because once we have hip dysplasia, follow them to maturity. So why do we follow them to maturity? Because she looks normal here. She looks normal here. She looks normal here. Why am I continuing to bring her back and look at her x-rays? Because it's like the growth charts. So you get plotted on a growth chart, and the next time they check your height again and your head circumference again. And again, and every time you're 50th percentile, and again, because you could fall off the growth charts. Okay, so she looked great, and we just follow them at intervals. There's no right number for intervals. As a broad thing, if we're treating them early, we're watching them a lot. And then we try to extend the intervals. But a critical interval is 6 months, so the pelvis x-ray at 6 months is gold standard. Another critical time point is 2 years, because that's when we start operating on bone. Everything after that is variable according to the physician. Okay, so I'm not right or wrong or anybody else, so I try to space them out. And then this is what she looked like. So can you guys describe this? Can you guys see? It's a bit faded, but can you see anything there that's abnormal? Yeah, exactly. You know, the patients get on my case because I won't tell them their Cobb angle for scoliosis. And I won't tell them what their acetabular index is for hip dysplasia. I kind of do what you do, which is it looks a little bit lateral. Because it is abnormal. And I'm worried about trying to put exacting numbers on things that are not that precise. But you can see, we just said that the hip is very constrained. The hip and the ankle cannot tolerate any deformity, okay? And this is just a little bit out, and it's uncovered. So we talk a lot in orthopedics about uncoverage, okay, or cover. Okay, so I'm gonna take a poll from the audience. By the way, I don't have an agenda here. I can just talk, and if you guys have questions, you can ask me questions. All right. But I'm going to take a poll from the audience. Who, when they go to an ice cream parlor, what do you guys like? The ice cream in a cup or the ice cream on a cone? How about in a cup? Oh yeah, that's right. Okay, what about on a cone? Okay, so one of the things I do when I get the ice cream on the cone is I immediately nibble the little bits around the rim, right? That is hip dysplasia. If you can remember that, you will not forget hip dysplasia. Seriously. And this is what I say to the families. So we talk about something called edge loading. That's a kind of biomechanics, physics thing. But when the server takes the cone, assuming they have a scoop, not one of these like fancy Italian things, but a scoop, and they push down the ice cream on the cone, everything inside that scoop is smooth. You agree? Everything on the edge bulges. Well, that's this. This is your scoop, and this is your ice cream. So what's going to happen on that edge? You're going to get edge loading. And that's the whole game in hip dysplasia when we operate on them. You're trying to get the ball to get inside the socket. And we want it to be concentrically reduced. Concentric. The center is con. Just there's a Latin prefix meaning the same. So the center of the socket, if I do a circle with the socket, the center is about here. The center of the ball is a little bit out. Okay, and if it's not concentrically reduced, it's going to be a little, as you said, a little bit out or uncovered. You're going to get edge loading. Okay. The other thing is, do you think it's wider here than it is here?
Yes.
It is, right? Okay, so this brings another sort of concept in my world. Does anyone know why motorcyclists wear leather? It's not a mystery, but did it ever occur to you? Aside from the fact it's stylish. Yeah, exactly. So what happens when they come off their motorcycle? They slide. Someone say slide? Yeah, they slide, right? They slide. So they want the leather to slide. Because what can their skin not tolerate? Shear. Can't tolerate shear. You'll rip your skin right off. You know another tissue that can't tolerate shear? Cartilage. In fact, cartilage doesn't really have any blood vessels going in. It works like a sponge. It likes to be compressed. And then when you relieve the force, not too much, okay? But compress, and then when you release, in come the nutrients, okay? And so when you look at an x-ray like this, and you see a gap, there's a little bit too much this way versus this way, this ball, every time this girl walks, she does axial load, compression, I like that. Shear, I don't like that. Over and over all day. Shear, 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 shear all day. And she'll wear herself out. And you can see she's beginning to get a thinner cartilage lip here. And you can even see that the ball is no longer spherical. She's only 13. Okay? So that's another thing that we look at. If it's a little bit out or uncovered, we're worrying about edge loading. And if the socket doesn't fit the ball, we're worrying about rattling in the socket, which is going to give you shear. Okay, so anyway, so she came back at me for the final x-ray, and I get the final x-ray at maturity. And what is maturity? I mean, a million ways to define it, but I think for girls, get your final x-ray after menarche. You figure they're pretty grown up by then. And if they look good, then you're done. For boys, maybe when they start to shave, something like that. Not regularly, but just at least they've tried it once or twice. Okay, so I'm supposed to. So I'm going to show you what we do, and then I'm going to stop talking. And if you have questions for me or for all of us, because I think questions are valuable, and we don't have enough time today for questions. I just put this in because I love his mustache, but I want you guys to see that, so in our world, remember that the shoulder, muscle-dependent rotator cuff surgery. Knee, ligament-dependent ligament surgery. Hip, bone-dependent bone surgery. We are not the original bone operators. Gilly was an obstetrician, and he introduced a saw to cut the pelvis for dystocia. This is from his paper, and I put it in. This is for our residents, these little vignettes I make, but I think it's interesting to you also. Imagine, poke, poke. There's a lot of traffic in there. And somehow he would just zip it around and then zip the bone and cut it in. This is his original drawings in a German, so that he could open the pelvis. So we still use that saw, at least I do. But we're not the originators. The OBs cut the pelvis before us. But this is what we do. Now, I don't know if this is going to work. I wanted it to work. Is our AV person here? How can I get this to play? Oh, it can play. Okay, so one thing I was thinking, I was talking to Dr. Swarup about this, and I've often thought I wished that our staff, so our office staff who schedules surgery, they should come down to the OR and see what they're scheduling the patients for. And I think primary care physicians should come to the OR every now and then and see what we do to your patients. Okay? But this is kind of what we do. So this is what a bone cut looks like. Can you see the arrow there, the white arrow? That's how we cut bone. And this is using the Gilly saw. It's pretty violent, right? But that's what we do. And then, oh, no, I'm trying to get rid of this slide. And then we use a lot of X-ray because what I need to do with this is take that socket that's like this and move it to here. All right? Do you guys remember the film Hitch with Will Smith? And he's trying to teach that guy how to dance. And the guy's flailing everywhere, and he's like, no, 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 from here to here. And it's a lot of surgery to go from here to here. But it makes all the difference to the ball, because it takes the edge away from the ball, so it doesn't grind it down, all right? So the patients suffer for, it seems like a small move, but it's a key move. And I won't bore you, but we use X-ray. I'm supposed to talk about open hip surgery. We use X-ray in the OR, and we have to cut around the ball. And then we do all this violence. I tell the residents that surgery is controlled violence. So I thought I'd just entertain you guys with a saw. I mean, I can't change a light bulb in my house, but I can do this. And I know it seems gruesome, but I will say to you, it is so great to do what we do because we actually fix patients. When I'm done with their hip, I know that they are better. There is no equivocating. There's an Arabic expression. So the English expression is the pen is mightier than the sword. Have you guys heard that expression, right? In Arabic, they say, but the sword tells the truth. And it's an interesting thing. I know surgery seems gruesome, but it is the truth. We fix the problem. And then I'm just going to show you this. This is the kind of stuff we do. We also use mallets. And I know it seems violent, but it's very controlled, and the patients do a lot better. And I'm going to show you now just the result. And what you can see here is that the ball now is tucked under the socket. So it's a lot of work and a lot of suffering because it takes a long time to recover from these things. But this space right here, this bone from here to here was down here. This space from here to here was down here. And so you can imagine how we rotated the bone to take the socket to tuck the ball in. And that now the ball is not going to get edge loading, and it's going to be more nestled in, so hopefully it won't be shearing as she walks. Okay, I'm going to stop there, and we can have more time to do questions and stuff. that's all I'm going to talk about for open hip surgery. I don't think you need to be told any more about what we do for surgery. Does anyone have any questions for me, or we can bring, or we can bring everybody up?